rest of the year.
Yes. I don't know if what Grace wants to do with you. I'm
well,
sure
Grace can do whatever she wants to do with me, I promise you.
Okay.
We can talk better about this later.
Yes, but now we are online, so people is coming.
Okay.
Music?
No music.
No music
today. Look what we have.
And I don't even have my
It's okay.
slides.
111.
Perfect. Yeah.
No, it's okay.
Okay, let's take a picture. Smile, Norman. Amazing. Hi, everybody. Welcome to Congenital Heart Academy. Today is such a special day. We are all of us live here. Oh, here, Professor.
Professor is here.
Okay, let's go to
someone have to sit here. Yes. No, please. This is your place. Yes, no.
You can sit, Professor, please. Anyway, everybody, thank you very much for attending today. I'm sure this is going to be a very, very special session. We have the super experts on Epstein here, Dr. Silverman on the echo perspective, and Dr. Luciana Fonseca da Silva and Dr. José Pedro Silva on the surgical part, and we are going to have a nice discussion today. So keep tuned until the end. I'm sure the discussion is going to be awesome. Please type your questions on the Q&A chat box. This discussion is going to be amazing. We want all of you to participate, please. Send now a message to your colleagues who are available so they can join this session as well. And if you want to check this later, or if you find it useful, send to your colleagues. It's going to be on YouTube after. It's broadcasted live on YouTube now as well, and then you can see this recording later. So today we're going to have a very nice session with Dr. Silverman talking about the morphological echocardiographic correlations on Epstein anomaly, and he has a very beautiful book chapter on that he's going to talk to us about it. So I have his book chapters, and I think they're all worth getting. So if you like, just go to the website that he's going to show you and get this book chapter as well. I'm sure you're going to enjoy. And now with you, our dear Dr. Silverman. Thank you very much, Luciana and José Pedro, for being here. And we are all here together in Italy, and Sasha's program in his hospital doing a nice Epstein cases. All of us are learning a lot. I'm learning a lot, and it's been an amazing experience. Okay, so thank you very much, guys. You want to say something? You want to say hi? Hi.
Hi, everybody. It's a pleasure to be here. Let's listen to
Okay.
Dr. Silverman.
Norman, all with you. Thank you very much for doing this special session for us, Norman.
Well, thank you very much, Grace. I'm going to share my screen with you, and you can tell me whether you can see it.
It's perfect.
Yeah.
Okay. It's a great honor for me to be here and have Dr. De Silva and Dr. Fonseca, who are acknowledged experts, with us for this session. I'm indeed honored that they have actually audited my session and provided tremendous and constructive criticism, and I'm sure that they will provide important information on this as we go through the session. Now, I am going to begin by just showing you the website where you can attain the copy of my book chapter, which is going to be uploaded to the website today or tomorrow. So this would conclude the 16 chapters that I've written on echomorphological correlations in all forms of congenital heart disease. Now, today we're going to talk about Wilhelm Epstein. Wilhelm Epstein was a 19th century physician of Jewish extraction. He was a very important physician in his life, and also a scholar of Hebrew texts. Unfortunately, no information is available on him because the revisionist Nazis in Göttingen destroyed everything that related to Wilhelm Epstein because of his religious beliefs. But he was born in Hauer in Prussia in 1836, educated very well in Breslau and Berlin, appointed a physician in Breslau in 1861, professor of medicine in Göttingen in 1874, and he died in 1912, missing the terrible First World War. When he was physician in Göttingen, he saw a young 19-year-old bricklayer called Joseph Presser in Breslau. He had shortness of breath, palpitations since childhood, was cyanosed, had cardiomegaly and a cardiac murmur, and he died in 1864. Epstein was trained by von Rokitansky, the great autopsy specialist, and he did the autopsy himself on Presser and called an etcher because there was no instant iPhone ways to take a picture, and made the plates that we see here of the malformation of Epstein's malformation. And here he looked at the atrialized section showing the dysplastic tricuspid valve, the displacement of the valve, the fusion between the anterior and inferior leaflets. And when he looked at the outflow tract, he could see this so-called keyhole orifice of the fused valve leaflets with secondary morphological attachments, hyphenated attachments, which we'll describe in greater detail throughout this session. And if you want to read the references, I have the reference here from the Mayo Clinic Procedures in 1979 by Gordon Lai and Ruth Mann. Now, what is Epstein's malformation? It is, in essence, a rotational displacement of the tricuspid valve from the atrioventricular junction so that the ventricle becomes atrialized. The displacement occurs in a spiral so that the anterior superior leaflet is attached normally, with maximal displacement occurring at the junction of the inferior and septal leaflets, and we'll show you that. The tricuspid leaflets are abnormal, and the septal and mural leaflets, mural, particularly the anterior superior leaflet, attached to the underlying myocardium, and is certainly, in listening to Dr. De Silva, I can see that what we can provide for him may be useful for him in terms of how he does the cone repair. The distal valve attachments to the underlying myocardium varies from a normal to a linear or complete attachment to the leaflets and may occur with any of the spectrum. Because of the repositioning of the tricuspid annulus, the tricuspid regurgitation is directed towards the inferior surface of the right atrium and the diaphragm. So now let's just do a little bit of pathology in deference to my other colleagues that helped me write this chapter, Bob Anderson and Diane Spicer. And here is a normal tricuspid atrioventricular junction opened. The red line indicates the atrioventricular junction and will be the same throughout the specimen. There's anterior papillary muscle, there's the medial papillary muscle and the inferior papillary muscle subtending the inferior septal and anterior superior leaflets. Here is the right atrium with its pectinate muscles and the oval fossa. Now you can see the difference between an Epstein's valve when it's opened, and I've drawn the attachment to the AV junctions, showing this sort of spiral displacement, but we'll see this in real time in greater detail as we go on. But you see the normal attachment of the anterior superior leaflet, and then the progressive displacement of the valve leaflet, giving rise to the spiral. Excuse me. And when we look at the heart from below, we can see in the normal heart the anterior, septal, and inferior leaflets. It is wrong, actually, to call this the posterior leaflet. The most posterior leaflet in an anatomically corrected place is the septal leaflet. So call it the inferior or mural leaflet. And here is its mitral fellow lying within the left ventricle. The Epstein's heart looks entirely different. Here we can see fusion between the inferior and anterior superior leaflets. The attachment of the anterior superior leaflet to the medial papillary muscle is not the single thing, but is a hyphenated attachment. And here we see the septal leaflet attached to the moderator band and the fusion between the septal and the inferior leaflet. So there's plenty of pathology going around. And unfortunately, this isn't the view that the surgeons look at. The surgeons are going to look at the heart from the atrialized section of the heart. And the labels will disappear for you. Here's another example, looking at the heart as we peer in the AV junction in the normal heart with the red dots, always red dots for AV junction, the anterior, superior, inferior, and septal leaflets. And here in Epstein's, you can see this rotational displacement from the AV junction. Here is the coronary sinus. That's very important. See how close the coronary sinus is to the septal leaflets. Here, the leaflets is spirally displaced as you see it over here, so that this becomes the atrialized right ventricle. And here are the septal and inferior leaflets joined and the anterior superior leaflet. So there's a great variability in valve expression in Epstein's malformation. And in the end of this example, in all cases, as some of the viewers may be looking at the presentation on smartphones, I have zoomed in each one of the examples, and I will not mention that I'm zooming them in, but you will see this throughout the presentation, that at the end of the presentation, we get a chance to give you the opportunity to look at the specimen and the echocardiogram unfitted by labels and magnified. Now here is an outlet view of abnormal right ventricle. Here's the anterior interventricular or left anterior descending artery. We see the moderator band. We see the ventricular infundibular fold and septomarginal trabeculation. And if you happen to be a Fanpragian, this is the parietal and septal band of the crista. Here is the moderator band subtending the anterior papillary muscle. And here lies the anterior papillary muscle between the medial papillary muscle, otherwise known as the muscle of Lancisi for our Italian friends, and the anterior papillary muscle. And on the right is this example of Epstein's malformation. And we can see all the same things. Here's the keyhole orifice. Here is the anterior papillary muscle. Here is the septomarginal trabeculation. Here is the ventricular infundibular fold, separating the valve from the pulmonary outflow tract, and the aorta on the top of this opened right ventricle. And we zoom in on this so that you can see this much more clearly. And you can see, in addition, the basal chordae that run right through this valve, and that this valve is far from the normal variant that we've seen here. And there's fusion between the inferior and the septal leaflets. And here runs the anterior superior leaflet separately. I beg your pardon, I've got that wrong. This is anterior superior leaflet and inferior leaflet fusion. And here is the septal leaflet. Now, Dr. Christian Schreiber did a series of dissections of this and drew these beautiful examples of, I think, 23 examples of Epstein's malformation, and looked at the position of the tricuspid valve within the right ventricle. Okay, he described this as the atrialized and ventricular specimen. And now let me just explain that this little yellow area here indicates the position of the transducer. Here's the transducer applied in the subcostal coronal pattern here. And we'll remove that, and now you can see the cartoon much clearer. And here is the reference to the cartoon and the picture from Anderson et al., the 4th edition of his Echo Pathology volume. So here you can see how the valve can be displaced. And the displacement occurs in a spiral way. If you look at this example of a, unfortunately, young man who had Epstein's malformation, a very old example, and the attempt was to close the atrial septal defect, which created tremendous pressure on the right ventricle, and he died within a day of being having his operation. So here's the oval fossa, and here is the position of the AV junction, always in red dots or red dashes. And here is the attachment to the underlying myocardium. And you can see a spiral displacement of this valve, maximum at the junction of the mural or inferior and septal leaflets over here. So the leaflet is displaced from its normal position at the atrioventricular junction to a variable degree. And on the right is an example I will use again and again to show the various features. Right atrium, here's where the atrioventricular junction should be. Here's where the valve is displaced to one of these places over here. The orange indicates the jet that will occur in tricuspid regurgitation. And we show the inferior, the inferior leaflet and the anterior superior leaflets here, giving rise to this little this functional right ventricle. This is the atrialized right ventricle over here. And here is the pulmonary valve with pulmonary insufficiency. So I'll put that in place, in motion for you. And I will show you in the series of examples here, the pulmonary insufficiency and the tricuspid regurgitation, rather than directed posteriorly because of the spiral displacement here, it's directed inferiorly in a subcostal coronal cut. So now let's begin by looking at fetal development, because the whole story of Epstein's begins with understanding what happens in the fetus. And the fetus has become very, very important in our understanding and also in our ability to perhaps select appropriate treatment. Here is a cut, a pathological cut from the Carnegie connection at 56 days or 8 weeks of development. And here is the right atrium, and here is the anterior superior leaflet and the septal leaflet of the tricuspid valve. And you can see that the septal leaflet is not delaminated from the underlying myocardium here. The ventricle is somewhat heavily trabeculated. Now, this is from a presentation from Walt Lummis and Jill Hicks-Boers, which has been published, and where they've taken the heart and they've created different sections of the heart. So the muscular septum is in green. The supraventricular crest here is in a dark green. The pulmonary valve leaflets seen above are seen over here. The AV canal myocardium, which is not fully developed at 8 weeks, shows the 2 leaflets of the tricuspid, not a tricuspid leaflet. And so this non-delamination of the valve becomes important. Now, this is a 19-week fetus. It's one of the earliest fetuses that was able to develop. You can see the descending aorta and the 4 chambers of the heart, LV, RV, RA, and LA. And that is even at this early stage, the presence of, in color, tricuspid regurgitation. So this is late, but we've seen Epstein's malformation in the fetus as early as 12 weeks. So between 8 weeks here and 12 weeks in the earliest representation, the presentation and development of the leaflets of the valve go on, and the non-delamination leads to the displacement of the septal and the inferior leaflets, which are still to develop at this early stage. So that's just like an AV septal defect. It doesn't develop until full expression until after the embryonic period. And now we zoom in on those things to show you the various examples. The next fetal development was made in 1989 by Dr. David Roberson and myself. We look here at a pathological example, and we see this purple here, which is the right atrium and the atrialized right ventricle. And when we put this as a denominator, and we put the rest of the heart as a quotient, we get a ratio of the this to this, which is called eventually called the Sellermeyer index by Dr. Sellermeyer. And you see here the atrialized right ventricle. And you see, as we take all of the structures off there, we see the raw data. We see the atrialized right ventricle and right atrium, and then the rest of the heart together. And this is from the patient that we saw. And as the quotient gets bigger of the numerator to the denominator, the prognosis gets worse. Fortunately, because of the ability of people like Dr. De Silva and the people at the Mayo Clinic in the previous iterations of surgery, have sort of violated the idea that the worse it is, the worse the prognosis. And certainly hats off to the De Silvas for their wonderful work on this. So here's the atrialized right ventricle. Let's take the labels off, and there's the labels off. And here's an example of a mild Epstein's in fetal development. These are all fetal echocardiograms. Atrialized and functional right ventricle, right atrium, and left ventricle. And you'll see as we take this off, as we start to look at that, this gets worse and worse. Here's the most profound form, because there's no tricuspid valve, because it's rotated so far forward in the 4-chamber cut that you can't see the valve. So we go from the mild to the most severe form of displacement of the valve. Here's another example in the fetus, matched with a postnatal echocardiogram, showing you the displacement from the mitral to the tricuspid valve leaflets, leading to an atrialized right ventricle. And here you can see a fetal example of the same, and worsened example with more displacement and more tricuspid regurgitation. Now, the displacement and the regurgitation are not always linear, but they tend to be. The more severe the displacement, the more the tricuspid regurg. But here's an example of profound tricuspid regurgitation, but the valve leaflets are fused to the underlying myocardium, and so there's no functional right ventricle at all, and there's just an atrialized right ventricle that develops here. So complete fusion of the valve to the underlying myocardium, or total non-delamination. And there's the big zoom for you. And here we're going to talk about this fetal example of the circular shunt. The circular shunt describes a feature where there is retrograde arterial ductus flow, pulmonary insufficiency, tricuspid insufficiency, and right to left atrial shunting. So the circular shunt, which my fellows call the circle of death, is a very important and a bad prognostic indicator. And so now we'll look at the ductus shunting right to left here, a little bit of pulmonary insufficiency, the tricuspid valve is displaced, there's a large right atrium and a small left atrium. The specimen shows the ongoing finding of this, where the pulmonary valve, because of the regurgitation, is held in the closed position and sometimes fuses completely here, giving rise to an atretic pulmonary valve. Here is the beautiful anterior superior leaflet, the septal leaflet, and the inferior leaflet looked from the outlet view of the right ventricle. And here is a probe placed in the valve, showing a membranous, thin area of total pulmonary atresia. And this is another example of short axis imaging, showing descending aorta, arterial duct, main pulmonary trunk, little tricuspid pulmonary insufficiency, tricuspid insufficiency with a big right atrium. And here you can see the bifurcation of the pulmonary arteries perfused entirely by retrograde flow. And the last example shows a high short axis view with the arterial duct, the left atrium, the pulmonary valve, and massive pulmonary insufficiency. So another example of the circular shunt, a bad prognostic sign. Now we'll look at fetal Epstein's and tricuspid valve dysplasia. And this is the cycle that goes when you get the Epstein's malformation with tricuspid regurgitation, which is really central to this. So when the shunt is central, this increases fetal central venous pressure and venous flow becomes abnormal, and the patient may develop hydrops because of the abnormal Starling relationship across the capillaries with increased venous pressure, leading to hydrops. The right atrium and right ventricle are dilated because of the tricuspid regurgitation and the to and fro flow across the ventricles. The ventricle becomes thin-walled and abnormal. There's decreased forward flow into the pulmonary artery. That leads to poor development of the pulmonary valve and trunk and pulmonary stenosis and atresia, pulmonary regurgitation if no atresia, and functional or real pulmonary atresia can occur. The pulmonary artery fills retrograde from the duct. There's more right to left shunting at the atrial level. This leads to poor left ventricular function, abnormal ventricular-ventricular interaction, abnormal strain and strain rate anomalies, myopathy and fibrosis. This causes decreased filling and compression and diastolic function and leads to left heart failure, and finally decreased cerebral and coronary perfusion, and that's it. So that's the cycle, and you can jump on anywhere in this bandwagon and create the whole cycle of things, and it's a malicious cycle which goes on and on and on. So now let's begin to talk about our postnatal assessment. And the views used to see Epstein's, of course, require several views. The display of all of the portions of the abnormality require a number of views, and they are a full complement of long axis, parasternal long and short axis, apical four-chamber cuts, subcostal coronal and sagittal cuts, suprasternal and transesophageal cuts, and TEE if proved incomplete after birth. So now let's just look at the shunts and the examples of what you can see. In the beginning, you'll see here parasternal long axis. You see the leaflets, the septal leaflet adherent to the ventricular septum, and the anterior septal leaflet, and the inferior leaflet leading to the atrialized right ventricle, with the left heart on the other side. And let's concentrate on the echocardiogram. Here's the anterior superior leaflet. The septal leaflet is plastered against the ventricular septum, and here is the inferior leaflet, and here is the left side, LV, the left ventricle, mitral valve, left atrium, and aorta. I won't necessarily speak to them, but if there's any question, please interrupt me with this position. So now we zoom in on this so that you can get a look at it, and that will be the format that I will be using during this presentation. Here is another four-chamber cut with the left ventricular outflow tract. Here, the so-called five-chamber view. You can see in this Epstein's malformation, the inferior leaflet is plastered against the ventricle. It has not delaminated at all. The atrioventricular junction is here. There's a small portion of the anterior leaflet, and the septal leaflet is also adherent to the underlying myocardium. So now when we look at, that's the inferior vena cava coming in there, okay? And so now here we see the anterior superior leaflet and the septal leaflet here, and the bulging of the septum back into the left ventricular outflow tract to a lesser degree on the left hand and a greater degree on the right hand. And you can see the various leaflets, the septal leaflet, the inferior leaflet, and the anterior leaflet. It's important to look at that because the adherence and the adhesions to the underlying myocardium are important for surgical consideration. And my whole attitude has changed as I look at echocardiograms. And I look at echocardiograms from the point of view as how I'm going to display the stuff to the surgeon, who probably can do well enough without me, but I need to show him or her whatever I'm looking at. So here is something interesting, because Dr. Jose and Luciana come from Pittsburgh at the moment, and this is a picture from the Pittsburgh archive that was given to me by Jim Robert Zuberbuehler. And so here you see the aorta cut in short axis, the right ventricle opened, the septal and inferior leaflets plastered against the myocardium and the anterior superior leaflet. Here is the AV junction. Here is the actual attachment to the underlying myocardium, and this area produces the atrialized right ventricle. Note also the position of the coronary sinus, because the coronary sinus is important in terms of looking at this. Now, the ink cut over here, I don't have another picture, is much lower than this picture here. So this is inferior and this is superior. So here we see now the septum, the septal leaflet, the atrialized right ventricle, the anterior superior leaflet, the medial papillary muscle, and the inferior leaflet here. So here you see the anterior leaflet and the inferior papillary muscle, and the inferior leaflet, the anterior superior leaflet, and the septal leaflet, and the bulging and compression of the left ventricle. And now we're looking at a zoom of this particular version. So this is the inferior leaflet. This part is inverted, one versus the other. Now we just turn the specimen round, and now we're looking at the infundibular area and the outlet. Here the scan is rotated up into the outflow tract of the pulmonary valve, and we can see in this postnatal example, one of the important information, the bifurcation of the pulmonary arteries in blue, the position of the pulmonary valve, which is insufficient, and here is the Doppler coming from descending aorta, across the ductus, into the pulmonary trunk, with retrograde fusion in the pulmonary artery. And we can look at this from the outlets, and this is a view that we often see in a more mild example, showing anterior superior leaflet, septal and inferior leaflet in a short axis image down towards the apex of the heart. And you can see the septomarginal trabeculation, the medial papillary muscle, the anterior papillary muscle, the septal leaflet, and the inferior papillary muscles down below. We can see the entire right ventricular outflow, viewed from the apex of the right ventricle and towards the right atrium here. Now, the four-chamber view was originally described in Epstein's disease by me in 1977, a reflection of my advancing age. And here is the apical four-chamber view removal over here. And we can see very beautifully here this picture that we've looked before, showing the atrioventricular junction, the plastered down to the septum, to the ventricular wall, the inferior leaflet, as well as the septal leaflet, which is displaced from the mitral leaflet, the left heart side on this side, the atrioventricular groove, and the anterior septal leaflet, the anterior leaflet, superior leaflet, which has got a number of these little tendinous caudal attachment that Dr. De Silva removes in the course of his operation. Now, in the second is a example of from Justin Tretter, my very good friend, that shows the fat of the AV groove, indicating the atrioventricular junction, the atrial shunt right to left at the atrial level. Here you see the anterior superior leaflet attached to the papillary muscle. You will see the mitral valve as we move on. And here is the atrialized and functional right ventricle that we've shown before. You'll notice that the left ventricle also has a lot of hypertrabeculations or spongy myocardium or isolated non-ventricular compaction, which you know about, left ventricular non-compaction that you know about. And you can see the dilation of the heart. I'll take the label so that you can see the anterior superior leaflet here, but no other leaflet is identified here. And here are the mitral leaflets. Now, the best way to look at the structures is by two-dimensional echocardiography, because even three-dimensional doesn't show the tendinous cords, whereas here you can see the tendinous cords that you see over here that need to be attached. And this is something we can display for the surgeon. We can also see where the tricuspid regurgitation is coming. And remember, it looks like it's really apical, but the ventricle is displaced. We'll see that in a few examples later on. Now, here's another picture from Justin on the same patient, which has been rotated in the magnet to look at the right ventricle between the atrialized and the functional ventricle. And here's the inferior and the anterior superior leaflets. The aorta is in the center. So here is where the AV junction usually sits. Here's the inferior vena cava that's usually in this region here. This is atrialized right ventricle with plasterized inferior septal leaflet. Inferior leaflet. The septal leaflet is not seen because it's out of the plane. So this is inferior leaflet and anterior superior leaflet here. Again, with the Schreiber diagram showing the difference between atrialized and functional ventricle. And again, we can do that with the echocardiogram with this great example that we have of this example showing the direction of, in orange, the tricuspid regurgitation. And the orange is usually, as the vertical dissection is in this direction, that tells you that the plane of the valve is at 90 degrees angle to the plane of the tricuspid regurgitation. So the tricuspid regurgitation also helps you look for the tricuspid regurgitation. And I'll just enlarge this so that you can see that. So the regurg 90 degrees to there is the AV junction over here. Now we look at the subcostal sagittal plane, and here we have front and back, top and bottom, top, bottom, front and back. Never mind about the right ventricle over here. We're looking from the right atrium. So this is the so-called keyhole orifice with the fused valve leaflets. And here you can see the fusion of the valve leaflets across the inferior and anterior surface of the right ventricle. And you can see the relationship of the right and the left atriums. Now here's the inferior vena cava. The normal septal region is in this region here. But here it is all the way around here, and this is all plastered down inferior leaflet, which is not delaminated. And a more mild example on the right side here, little less displacement of the inferior leaflet from the inferior cava and the junction of the jet towards the diaphragm. Now, what's most important is when we look at this in a biplane. Now, I have two specimens. You'll see this specimen a little later. We've seen this a little further. And we have got a fix of this in the two planes. This is the same patient. The ECG here shows a little electrical interference from one's hand coming across and causing an arc in this. But now here we've seen both of these pictures before, and you see the direction of the tricuspid valve, the position of the atrioventricular junction, and the attachment of the valve to the underlying myocardium. You see how small is the functional right ventricle in this heart, and you see that the valve leaflet is rotated round up towards the outflow tract. And so this is a biplane example of this, with this exquisite example of the inferior displacement of the tricuspid regurgitation and the various aspects of the heart, including the fact that the pulmonary artery is patent in this example. Now, I've developed a mnemonic for Epstein's malformation, and I call this the dozen Ds of Epstein's malformation, describing this, and we will look at each one of these issues as we look at the tricuspid valve. This is displacement of the proximal attachment of the valve. Dysplasia of the valve. The valve is often dysplastic. There's distal attachment abnormality, so important for surgical consideration. Dysplasia of the underlying myocardium, which we can do something to help with an annuloplasty. Dysrhythmias, because arrhythmias doesn't have a D in it. Doppler evidence of tricuspid regurgitation, because there's no a D in tricuspid regurgitation. Dysfunction of both ventricles, both systolic and diastolic, which we've referred to from fetal examples. Dilatation of right heart chambers, arterial duct associations, deformity of the right ventricular outflow tract and valve, other defects, and finally, from even fetal examples, death is a problem. Now let's look at the proximal attachment in the four-chamber view. Here's the four-chamber view, apical four-chamber view. Here you see your Eustachian valve and atrial septum and the displacement that is seen in the apical four-chamber view. And we described this finding in the 1980s early to show that the chief feature of Epstein's was the septal leaflet. That was old-fashioned, but it certainly was the first a real example that people could believe about the displacement. And the displacement goes on from mild to severe in these examples, and they're all four-chamber views, and I'll take that out so that you can look at it, and you see then the association of tricuspid regurgitation. And here's an example of lesser regurgitation with more tricuspid regurgitation and more displacement with lesser tricuspid regurgitation. Okay, now one of the things that we have to consider is that people have done a construction to measure this. In adults, it's 8 millimeters or 8 millimeters per meter squared if you're looking at children, is how you get it. And these two plain cuts here are an anterior four-chamber cut and a posterior four-chamber cut. And when you see the anterior four-chamber cut, it's quite a lot more smaller than what you look at the four-chamber cut posteriorly. So remember, when you're looking at your scan in the four-chamber cut, to look at the most posterior correction just before you see the coronary sinus disappear in a cranial direction. And you see how the displacement is magnified in this direction and allows you to make this diagnosis clinically. This is the same patient, the same scan, looking from a inferior to from an anterior to a posterior scan. So this is the scan you want to use posteriorly. Remember, put your plane back there. All right, so now here we'll look at the displacement of the proximal attachments of the tricuspid valve. Okay, so you see here the normal heart with a four-chamber cut, and here a heart with mild displacement of the tricuspid valve leaflet. And we've opened the right ventricle. Here's the flap valve of the Eustachian valve, the oval fossa, the atrioventricular junction, and the spiral displacement of the septal and inferior leaflets. And in the four-chamber view, we've seen this picture before. We see the AV groove. We see the separation between the mitral and the tricuspid and the atrialized and functional right ventricle. And we can also see as we look at this, the moderator band, which is attenuated by the dilatation that's occurred in the right ventricle. Here's another example of a mild displacement of the septal leaflet. Here's the valve junction, and here is the attachment. So this here is the atrialized ventricle, and this is an area that Dr. De Silva has shown you how he delaminates this surgically in doing the construction of the cone procedure. And here we can see the septal leaflet, which is separated from the mitral valve, plastered against the ventricular septum, associated with tricuspid regurgitation. And as you look down at the apex, you can see these tendinous cords as well off the anterior superior leaflet that are going to be removed. And here is the equivalent to what we saw in the four-chamber view, using the subcostal view to show how, as the leaflets develop in progress, you get a progressive displacement of the junction using the Schreiber approach, and how beautifully you can see this without looking at an autopsy specimen. But if you want to look at an autopsy specimen, there's the apical four-chamber cut, and there's the position of the AV junction and the inferior leaflet attachment here, the septal leaflet plastered down against the ventricular septum, and the junction of the superior leaflet. And they move in real time. And once again, we can look at this with the, as we've seen before, the same features. Here is the atrioventricular junction attachment, and here is the real junction of the valve here, and the atrialized right ventricle showing the inferior leaflet attachment. And we've seen these pictures before. So in the interest of time, I'm going to go through these and zoom in on that so that you can see the zooming. And here again, you see, even though the tricuspid regurg is more usual in position, it's still diaphragmatic in its position. And here is the space between the coronary sinus inferior vena cava and the attachment of the valve. So this is where the junction should be. Now we're going to look at the dysplasia of the valve. And here we know is this marked dysplasia of the valve. The valve leaflet here is got several fenestrations in it. This is the septomarginal trabeculation. And there's this verrucous attachment which looks like totally infunctioning inferior and septal leaflet. Again, we can look at the valve leaflet and we can see these strands of tissue in papillary muscle and cords, etc. over here. The valve leaflet is tethered and doesn't delaminate properly. And as the patient grows, this gets worse and worse with more dilated right ventricle and shifting over of the structures on the left side. There's also an atrial septal communication at oval fossa level. And of course, just to look at what happens with color flow, a huge amount of tricuspid regurgitation is noted. Now here's some more tricuspid valve dysplasia. Relatively normal leaflet here, but with, as we'll get rid of the four-chamber cut, you can see the inferior and septal leaflets are remarkably abnormal. And in this incomplete echocardiogram, you can see non-delamination, non-junction of the valve in systole. So there's massive tricuspid regurgitation that developed in this neonate with this condition, showing a subcostal coronal cut. And here's another example of tricuspid valvular dysplasia, here of the inferior and septal leaflet. The septal leaflet is plastered down. This is all atrialized right ventricle. Anterior superior and inferior leaflet are the only ones shown here. Inferior and anterior leaflet with the underlying atrialized right ventricle. Here is the inferior vena cava. So this is all atrialized right ventricle here. See the superior cava coming in here, and the valve almost looks like cystic structures with numerous attachments to the right ventricular anterior wall. Now, I like this picture. It's from the UCSF archive, and it shows the atrioventricular junction displaced, or the attachment of the valve displaced here. Here's the atrioventricular junction over here. And what I want to do is show you the anterior superior leaflet, and you can see the basal chordae running all the way through the valves. The valve leaflets are thickened and valved, and the chordae tendineae are really abnormal on this valve. And wait, this is the normal looking valve because of its normal attachment. But the displaced septal and inferior leaflets are also way out of this. And here we see in this fetal example, which we've seen before, the development with prolapse of the valve tissue because of the inadequately developed tendinous cords and delamination process, and also an abnormal anterior superior leaflet as well. So dysplasia is a function of the tricuspid insufficiency. And here's another example. And here we see the verrucous attachments and the rolling of the anterior superior leaflet normally attached, but the septal globs of the inferior and septal leaflet are shown. And here is an echocardiogram showing you the same. Again, the thickened rolled edges of the valve leaflet and the attenuated moderator band, which you'll see here in a moment there in the echo. Now, tricuspid regurg, as we've mentioned, tells you something about the valve. It tells you that if you see where the valve is, and that's usually directed in a perpendicular direction to the valve plane, you can work out the direction of the valve attachment. And here is such an example again, showing a complete linear attachment to the moderator band. We'll see that momentarily. We've seen that picture. Here's another picture here showing pulmonary insufficiency and tricuspid regurgitation. And when you put the Doppler on the tricuspid regurgitation, the signal shows a forward velocity towards the diaphragmatic surface, indicating the presence of the valvar annulus in green, as I've shown you over there. Here's another example of severe tricuspid regurgitation that you will present with in a severe neonate. The valve looks fairly good, but there's massive tricuspid regurgitation. You can see the Eustachian valve or valve of the inferior vena cava and the displaced atrial septum over here with a small left atrium and massive tricuspid regurgitation. Now, the distal attachment has been stressed very much by Professor Anderson in this, that is important for the surgical repair. And here are examples of variations in attachment of the anterior leaflets. Here is the anterior superior leaflet, which has the linear attachment, the septal leaflet we've seen plastered down, and the inferior leaflet down the bottom. Now, when we look here, this is normal focal attachment of the valve. Here we see the so-called hyphenated attachment with multiple tendinous cords and multiple tendinous cords going across to different papillary muscles. Here is a more advanced variety showing the septal and inferior leaflet fusion, the anterior leaflet with modification to the muscle of the conus or medial papillary muscle with attachments all over and even a linear attachment distally. And here the profound variety of distal linear attachment of this anterior, superior and inferior leaflet, which are fused, giving rise to the so-called keyhole orifice into the pulmonary trunk here. So this is all functional right ventricle here, and the secondary orifice down here. So what I want to stress is that I've put this down in as a linear recognition of progress, that in fact it's a spectrum of disease and not a singular thing. And here these are just milestones along the spectrum of the distal attachment. Now, I think I'm spending a lot of time. I don't know, Grace, how much time I have here, but here's the so-called keyhole with the anterior septal and inferior leaflet fusion. Here's the papillary muscle. Here's the medial papillary muscle. I think we've seen that before. I won't discuss it any further, but here you can see the distal attachment of the valve here to the medial papillary muscle. And also, when we look at this over here, we can see, again, profound attachment together with pulmonary insufficiency in this group of echocardiograms. And the anterior leaflet tethering, which I've mentioned so often before, which I think I'm just going to rush forward through because of the interest of time, and we've seen all of these echocardiograms that you can look at again when you look at the replay of this or on the app that I've made. And here's septal leaflet tethering. Here you can see no tendinous cord, but definite tissue plastered down that Dr. De Silva would probably attack from the atrial surface to remove it. And here you see the septal plastering both postnatally and also to stress that this begins prenatally in utero. Here you see that same picture that we've shown before as well. So this is a disease that begins and it exacerbates worse and worse as the rising pressure and demands on the right ventricle occur during fetal development. Now, not only the anterior leaflet, but the inferior leaflets are tethered. Here's the inferior leaflet, here's the anterior superior leaflet, there's the muscle of Lancisi, here's the septomarginal trabeculation, and this is the fused septal and inferior leaflets with a tethering of this leaflet across here. Now you'll see a subcostal coronal series of pictures that shows this inferior leaflet tethering that I've shown by arrows. That's all inferior leaflet, and that's the anterior superior leaflet there. And here is the tethering coming all the way across here in another example. So that's inferior leaflet tethering. And here's another beautiful example showing a specimen with the basal chordae running all the way through the septal leaflet. And here you see it on the echocardiogram as well, with the tethering of those tendinous cords, together with the fact that there's also spongy myocardium or hypertrabeculation, excessive trabeculations seen, and this occurs in about 15% of Epstein's malformations as well. And here's another example of anterior leaflet hyphenated attachment. And you can see all of these little attachments to the underlying valve there. So important in terms of making the rotational adjustments. And here we're getting down towards a almost complete obstruction of the valve with only a small little hole between the pulmonary outflow tract over here. And the rest of the heart is all tethered down. And here on the echocardiogram, you can see that. You know it's not complete because there's still tricuspid regurgitation into the proximal attachment of these various leaflets, but you can see the anterior superior, the septal, and the inferior leaflets as they move away from the right ventricle. And then here's a complete obstruction. You see the ventricle is hardly moving, but neither is the valve, and there's no attachment. I'll show you another example of this associated with a ventricular septal defect. Now, understand that Dr. De Silva thinks he could fix this easily because he just has to delaminate the valve. But this patient also had muscular ventricular septal defects to the lower portion and into the pulmonary artery. And they were such a size that they were almost certainly pressure restrictive with no increase in flow. The ventricular position was changed so that the papillary muscles were displaced and caused mitral valve prolapse in addition to this finding. Now, dysplasia of the underlying myocardium is perhaps a long stress because we cannot see dysplasia with an echo. but we can see this fibrous aspect of the replacement fibrosis that occurs on the underside of the right ventricle. This is the anterior right ventricular surface. Here's the AV groove here, and you can see the whole atrialized right ventricle has become a fibrous band, and the muscle has been replaced. You can see the tissue towards the outflow tract there. So that ventricle is only moving with the atrium and not has any intrinsic function at all. And here again, we can see the dysplasia of the underlying myocardium. Here, we've seen that picture before. And then what happens to the pulmonary valve? I've only included this one picture, which we've seen before with pulmonary atresia, and 2 M-mode echocardiograms obtained in the 1980s. This at 20 weeks of gestation, showing beautiful opening and closing of the pulmonary valve. And at 36 weeks, when we saw it again, 2 weeks before the baby succumbed in utero, there's almost no motion of the pulmonary valve because it's entirely fused over. So there are certainly abnormalities that occur in that direction. Now, malformations associated with Epstein's, it's frequently found with the morphologically tricuspid valve with left-sided morphologically tricuspid valve with discordant atrioventricular connections, which we often call corrected transposition. It's found with atrial septal defects almost universally in the oval fossa, ventricular septal defects, membranous muscular or outlet, pulmonary stenosis or atresia, 8 to 10%, and excessive trabeculations, formerly called spongy myocardium. And I have examples of all of those for you. So here is an example from the Brompton Hospital archive. And you can see here the anterosuperior or just superior leaflet, because this is the morphologically left-sided right ventricle, giving rise to the aorta. So discordant atrioventricular connections. This is the right ventricle, morphologically left-sided right ventricle, with the ventricular infundibular fold and septomarginal trabeculation, septal inferior leaflet, and superior leaflet, which are abnormal with a lot of obstruction here because of the massive hypertrophy of this right ventricle demanded by the systemic circulation. And here is the echocardiogram, which shows the displacement of this valve in the left-sided morphologically right ventricle and the AV valve regurgitation that occurs in this condition almost invariably as well. And this is a false tendon, not usually seen in the right ventricle, much more common in the left ventricle. Another example showing, again from the Brompton archive and published by Dr. Leon Gerlis and myself, showing the septomarginal trabeculation, the attenuated moderated band, and the thick abnormal tricuspid valve, and the displacement on the echocardiogram, as we see here. And a beautiful example from the archive of Diane Spicer, showing the position of the apical four-chamber view. This is the left-sided morphologically right ventricle, anterior superior leaflet, the atrioventricular junction always in red, and the displacement of the septal and the inferior leaflets in green, and the echocardiogram shown over here, which clearly shows this abnormality. Now, we don't call it Epstein's, we call it Epsteinoid because there is no attenuation of the proximal attachment in congenitally corrected transposition. And now here, associated ventricular septal defect, this patient without congenitally corrected transposition. So this is pulmonary outflow tract. Here's the terminal crest, I beg your pardon, the supraventricular crest and the moderator band, and a ventricular septal defect in the membranous area, as we see here, only really well described when you see the AV septal, the Doppler color flow image. And in the bottom image, we see a muscular ventricular septal defect with the left ventricle being, as explained here, exposed, and no evidence here of in congenitally corrected transposition, the Epstein's valve in this example. Now, the spongy myocardium, here you can see the spongy myocardium. We've seen the specimen before. Here's the spongy myocardium on the left side of this Epstein's malformation. And here, and you see on the echo with Doppler color flow after birth in the same patient, you can see the interstices of the spongy myocardium as it extends almost to the surface of the heart. I'll show you some more examples here. We'll take this example and we'll turn it on its side. Here's Dr. Tretter's example, which show you the spongy myocardium, even on MRI, beautifully demonstrated. Okay, it's not so easy to see when you look at it on its side, but when you look at the postnatal echocardiogram, you can see the nature of the apical hypertrabeculations, the presence of a small pericardial fusion, and the fact that almost all of this myocardium is spongy rather than any compact myocardium present over here. And this patient underwent a transplant. Now, for most patients with we have the right ventricular exclusion operation or the Stans procedure. And here is this procedure described by von Stans, where he put a patch over the AV junction, left a little hole to decompress it. And here is such an example of a patient that might undergo a Stans procedure. Look at this massive right ventricular and right atrial enlargement, the non-function of the left ventricle. And here from my own collection, Dr. De Silva, is a patient with a Stans procedure. I spent a period of my existence, probably at Stanford. And so I got to see a lot of this very popular operation there. And so you can see here, the left ventricle has sort of changed its size. The right ventricle is functioning much better. And there's just a little to and fro flow coming across over here. And of course, there's a shunt, obviously, to deliver pulmonary blood flow. And then, of course, I don't know whether I should do this, but this is, I'm sure you can do that much better than I can, but this is from your own pictures, Dr. De Silva, which show the appearance of the AV junction, AV junction, true atrioventricular, you call it annulus. Dr. Anderson won't let me use that term. We call it junction because there's no real annulus of the tricuspid valve, according to his measures, histologically. But here is the valve and the spiral displacement. And then here, the delimitation of the septal and the inferior leaflets, the rotation round, the fusion of the leaflets, and then an annuloplasty to reduce a reduction annuloplasty to reduce the size of the functional ventricle and make a cone procedure of this, as we see this down below, with the valve leaflet beautifully displayed. And then from your own institution, courtesy as Elizabeth Lanford, we see a black and white image of the cone. And look at how beautifully the right and left ventricles are functioning, completely changed. And then here you can see the cone jet coming into the ventricle. There's certainly acceleration, but where is the tricuspid regurg? There is none. And then these are pictures I got from my good friend Joe Deraney, which show you his cartoon plus the specimen of this. I wanted to be ecumenical, Dr. De Silva, because I've had so much experience with my good friends at the Mayo Clinic on this issue. So in the summary of Epstein's, we said that's a rotational deficient position displacement of the AV junction, and it becomes a spiral so that the maximum displacement is at the junction of the inferior and septal leaflets and what the tricuspid regurgitation is. The valvar orifice is formed at the junction of the atrialized inlet with the functional ventricle. The major surgical variation involves the distal attachment of the anterior leaflet, and malformation can be found with congenitally corrected transposition. And don't forget the associated malformations. Now that concludes the Epsteins. I have 3 or 4 slides left. I want to ask the presenters whether I should stop now or whether you want me to just show the issue of tricuspid dysplasia.
Normal, I think if we can stop, because soon Luciana needs to go to the OR. So I think we can focus a little bit
Good.
more
Well,
on the discussion.
I'm sorry that I can't show you tricuspid dysplasia, but you'll see
Can
this
add
on.
in the next webinar for sure.
Okay. Well, you'll tell me when that is, Grace.
I will. We're going to talk about it. Guys, thank you very much. Normal, it was amazing. We are going to start. We have a very, I'm very happy that Gil is with us today, and he's going to talk a little bit about the World Congress, as we talk in every webinar. And then today he has a special announcement and something nice to show to all of you. Hi, Gil, how are you?
Hey, can you hear me? Okay, how are you? Norman, that was just spectacular. I love the juxtaposition of the anatomic specimens and the imaging. I don't think I've ever understood Epstein as well as I do today. So thanks. Thought that was great.
Thank you very much.
I want to see if this works. I've been doing Zoom for how long now? Let's see if
almost 3 years.
yeah. What do you see now? Because I have 2 cameras.
Yes, you need to put on presentation only, presentation mode. But we can see your screen. Now we cannot see anymore.
I can hear you now, finally.
Okay. Oh, good. But now we cannot.
Yeah, this is all new for me.
Yes. Just a second, Professor. Come close. Let's take a picture. Gil, smile. Norman, smile. Amazing. Thank you. Okay, Gil, go ahead.
All right. So now I'm going to try to get this on presentation mode. Do you see presentation mode now yet or not?
Not yet. No, we only see you. It's not, your screen is not shared.
Okay. So
I need to stop sharing my screen, huh?
I think you did already, Norman.
Okay, all right, good. I'm off.
okay, I will try now to share my screen. For some reason, I don't have the that little
green
thing.
button?
The little thing that comes with Zoom. Is there a way that you can share my screen?
No, not yours. No, I can't.
That's true. Oh, there it is. I found it. It was hiding in the back.
Okay, sounds good.
You should be able to see the slideshow now.
Yes.
And is
yes,
it
go
is it
to
in
the slide
presentation mode?
Yes, now it is. Perfect.
Okay, good. All right. I can guarantee you that the World Congress of Pediatric Cardiology and Cardiac Surgery will go much smoother than my ability to show these Zoom slides. And of course, it's stuck again. All right, let me just try one more time, and then I'll let the Silvas present if I need to. Okay.
You need to go to share screen again.
No, those were not, the problem is those were not the slides.
You have 2 screens, right?
Yep,
Yeah, that's always the issue.
yep. All right. If I get disconnected, please have the De Silvas go.
Okay, sounds good. But I really want to see what you have to say. Let's hope it works. Okay, I think now he got disconnected. He is going to
Anything
come
now?
back.
Last chance.
Okay, your video we cannot see anymore.
That's a perfect presentation. I hope that wasn't referring to mine.
But we can
Yeah,
hear
for some
you.
reason, these are not. picking up. All right, what I'm going to do is I am going to get off. I'll let the De Silvas make their presentation because I know they have to go to the operating room, and I'll come on at the end, assuming there's time.
Okay.
Sorry about that, everybody.
Thank you very much, Gil. But anyway, guys, whoever needs to leave before Gil is back, don't forget, end of September, end of August, beginning of September 2023, we have the World Conference. It's going to be amazing. Save the date. Okay, so Norman, it was an amazing presentation. I'm sure everybody enjoyed a lot, and we have a lot of questions for you. We are just going to start some comments from Luciana, who has to go to the OR, do a beautiful Epstein and as well. And I just want to comment before she says that how echo could be accurate, the amazing colleagues here from Taormina doing great echoes, and how she could, looking at the echo, describe exactly what she was seeing, what she was going to see in the OR minutes later. So it was something that could show me as a clinician how important echo is and how important it had someone with great experience and knowledge on that. So it was really amazing to see how echo could give all the answers that needed to be done. Okay, Luciana.
Say one thing about echo there, because I mean, you've got wonderful new techniques, and well, we didn't describe, you know, the strain and strain rate, which is abnormal in this condition. But for echo, for definition, there is no technique, especially when you're thinking of things like tendinous cords and things like that, and the attachments of the valve, that you can see better on 2D echo than you can on 3D echo or an MRI or CT. I mean, I think that those are some of the strengths of echo that perhaps are weakness of the other techniques. So I think that that's true, that, you know, this has sort of been a lifelong learning experience for me, where really accelerated tremendously by what I've learned from Dr. De Silva and Dr. Fonseca about this. And they really are amazing that you can see these things now and where they take us. And to remember that the battle for Epstein is waged in utero, not ex utero.
So, Dr. Silverman, I just want to thank you for your contribution to the Epstein's anomaly field. And I was amazed by your chapter in the book. That it's a great, great contribution. And I loved your presentation today. So you and Dr. Zuberbühler from UPMC in Pittsburgh, and Dr. Anderson, and later on Dr. Schreiber, you guys are amazing. You made a lot of contribution to the understanding the anatomy and the embryology of Ebstein's anomaly. Thank you so much. And I really appreciate your book. I think you make it more easier for us to understand what we are seeing in the images of the echo and correlate with the findings in the surgical field. So this is really amazing. Thank you so much. And we are pleased to have Grace and Dr. Gilvernovsk and Dr. Sasha spreading the knowledge about this and spreading the knowledge about the surgical techniques in other fields also. So thank you, Grace, for the opportunity to be here today. And we are doing many, we did already 4 cases for Epstein's case. We still have 1 more to do, so I need to go. I will leave you here with Jose.
Well, just let me thank you so much for that. Most greatest honor I've received from you is your appreciation of my work, and I'm absolutely honored beyond belief. And I hope that we can continue to have an association. We're not more than a plane ride away from each other now, although I do acknowledge all of my friends in Brazil, like Vera and Lillian Lopes, who have helped me over the years with work and understanding of diseases. So I hope that we can continue this relationship and this dialogue. And I'm really very honored by all of the efforts that you and Jose have done for me in helping me refine the quality of this chapter.
Thank you so much. It will be a pleasure to continue the communication with you, and it will be an honor to have you in Pittsburgh for a meeting. I want so much to see echocardiograms with you and show you videos in the findings, the operation we have done there. So we are recording everything, so it will be amazing to have you there, so we can share ideas and.
Well, it would be a wonderful experience.
It would be a great experience.
And I must just thank Sasha and Grace always. I mean, I feel, you know, it's hard to give a talk by yourself. And I feel I'm never alone when Grace and Sasha are with me to help me and support me in my presentations.
Norman, you are always amazing, and we've been learning a lot with you. Thank you for your generosity for sharing all of this knowledge. Really, thank you very much.
I'm going to the OR to see if they are read there. If not, I will come back. Okay, bye.
Okay.
Thank you, Luciana. Thank you very much. I think Gil has a question and a comment. And Gil, do you want to try to show again, or do you want to do this in the end?
I can try. Norman, again, great presentation. I thoroughly enjoyed it. I have a comment and a question. The comment first is you showed this great cycle of how the tricuspid regurgitation begets all of, you can jump on that circle anywhere you want, but it just becomes a cycle. And you said the battle is fought in the fetus, in utero. And this, you know, we get in the ICU the presentation of these babies with high drops, if they make it, with high drops and pleural effusions and ascites and all the rest of it. I guess one of the questions I have with the decreased forward flow through the ductus, as opposed to with tricuspid atresia, have we looked at placental flow in this disease? Is part of that restricted forward flow placental insufficiency causing some of this problem?
I've not looked at that personally. You know, Jack Rychek is doing work on the placenta now. And the placenta is a really, I mean, it's an overlooked area. It's the pink elephant in the room that we haven't paid much attention to. And he's found in a number of congenital heart diseases that there is really a profound change in the placenta as well. And then let me point out to you as well that, I mean, the placenta is subject to the same increase in hydrostatic pressure in this condition with hydrops. I mean, the hydrops is a placental dysfunction as well, because when we look at the Starling relationship across the capillaries, whether they are in the placenta or whether they're in the baby, in the fetus, there is an increase in venous pressure, and the relationship of ingress to egress of extravascular fluid is completely changed. And the fetus is at much greater risk than anything else, because the albumin in the fetus is much lower. And so oncotic pressure in the inside is much reduced. So the fetus is much more critically exposed to issues of hydrops, and I'm sure that they occur across the placenta as well.
That's a good point. What your fellows called the circle of death continues in the ICU, as you well know. There's really no good medical therapy, and if our job is to get the patient in the best possible shape for Jose and the surgeons, this is the tough. You know, the battle starts in utero, but it sure continues pre-op in the ICU.
Gil, I mean, I'm pleased to have you here, because I'm talking about ecomorphological correlations, but basically we're interested in the disease and how we can help the patients. And maybe you can say something about Lisa Hornberger and her colleagues in the past have talked about the use of non-steroidal anti-inflammatories to close the ductus in this condition, and the use of nitric oxide to lower the pressure, anything to get the right heart to function better than you can. And you say something?
Yeah, there's some good anecdotal experience that most of us have with the combination of lowering the pulmonary vascular resistance and closing the ductus. The challenge that always gives me tachycardia is having an open ductus and nitric oxide on board, which only steals systemic circulation. And so the timing of ductal closure and the institution of nitric oxide is the key part of that. And it helps you determine whether you have functional, as you described, functional or anatomic pulmonary atresia. If the aortic pressure, for example, is 60 and the PA pressure is 60 because this duct is non-restrictive, and the RV can't generate a pressure of 60 because of TR, the pulmonary valve does not open, even though it may be anatomically patent. So sometimes the only way we know that we can get antegrade flow is the combination of no ductus to let the PA pressure be different than the aorta, and then nitric oxide to drop the pulmonary resistance. But it's a very tenuous time for that. And I would only try that if the echo people, if your team can show just some degree of pulmonary regurgitation. All I need to know is that there's a little bit, and then you can say it's not that it's not atresia. But these, unfortunately, these are the kids who, as we talked about, massive heart, lots of effusions and all that stuff. I think I'm very curious what I used to say my Brazilian colleagues, but now my Pittsburgh colleagues would say about the use of a cone procedure in bad neonatal Epsteins. Maybe I can toss the question back over to them. Are you going to talk about that in your presentation, John? Or?
We are not presenting today. We are just discussing because we have a busy day here. So the plan would be just, and the lecture was important, was Dr. Silverman telling us about the correlations. So we will not talk about that.
Grace, I'm sorry, Lieutenant, this is something we'll put on one of our next webinars for sure. Because neonatal Epsteins, that battle, as you said, Norman, that starts, well, they're all Epsteins. The baby that presents sick as a neonate still doesn't have a good therapy, in my opinion.
Yes, we are doing, like we have our symposium in that Grace spread the news also about it.
So
the symposium about Epstein's anomaly in Pittsburgh, and I give a lecture there about neonatal Epstein's. And our approach now is very concise. Like some patients, we need to do BT shunts or stent in the PDA if they are low flow and small size of the heart. Other patients, we need to do stance procedure if the heart's too big and there is some degree of heart failure. But most of the patients we need to wait and see how they do. Like you said, some of them, they will follow the clinical treatment pathway and later on the cone procedure. So at the end, we are doing in Pittsburgh cone after stance. So this is a great challenge in the treatment of neonatal Epsteins, because we don't need to choose anymore which patient we follow, the single ventricle pathway or the biventricular repair. We can do the stance, but we just need to leave the patch of the stance a little bit inside towards the atrial side to avoid the leaflets to attach to the patch. Another trick is to use Gore-Tex patch, not pericardial patch, to avoid that attachment. So, and later on, we can remove the Gore-Tex patch and do the cone. We did that.
Wow.
In some case, we had a publication. Jose is here. He can talk about that. And there was another case in São Paulo that Dr. Lilian Lopes treated the patient with the anti-inflammatory in a circular shunt, and then the baby was born a small size, and our friend there, Dr. Rodrigo Freire, did the stance procedure in the closure of the main trunk with a Gore-Tex patch, and then later on Jose traveled there when the kid was 7 months old, and did a biventricular repair in that patient. So it's a new situation now. I think we are more prone now to do the stance when there is a patient with congestive heart failure or even arrhythmias, and even patients on ECMO immediately after they are born. Sometimes they present very huge heart and bad arrhythmias, and they need to go on ECMO. This is, in our experience in Pittsburgh, we have a good solution for that now. I think Jose has something to tell.
Yes, yeah, Luciano, we told you we had a program full of cases here. We did 4 cases. We have another one to go, and today was 3 days, 3 cases. They were on vacation in Europe. Now we are in Taormina, where we did those cases. So first I want to congratulate and to thank Dr. Silverman for his spectacular presentation. I have to steal that word because I had written my paper here. It's a really spectacular, and that that combination of showing specimen and show many forms of image, especially the echocardiogram, is very interesting. Like 20 years ago, we would not understand very well the anatomy. We know of Epstein, have regurgitation, but we didn't know the details and of the disease. And nowadays, with presentations like those, make our life much easier. I was amazed with the way he illustrated the 3 different distal attachment of the tracheal valve leaflet in the Ebstein anomaly, like the linear attachment, and then like when you have a more mobility of the leaflet, so you have like focal attachment with near normal, and especially those 2 forms that when you have a linear attachment, it means that the surgeon has to delaminate the leaflet from those abnormal muscles, papillary muscles, to the more distal part of it. And that means that then you have a big leaflet with no perforation, no inflow. Then you have to create fenestration. And basically you end up with like a membranous type of valve. So it was very interesting to see the image that has shown, because then you are more prepared for that. The other thing that's important is to show, to see how rotated is the valve. When you have the valve rotated to the outflow tract, open into the outflow tract of the right ventricle, in the past, it used to be equal to replace the valve. Now we know that we can repair that. We can take down those abnormal attachment. Then we close that hole, and the valve then come to the middle, to the center of the body of the right ventricle, instead of going to the outflow tract. And that helps in closing the hole there. So understanding the anatomy is very important to know what we can do. Luciano was commenting on Dr. Gilbert's about the difficulty with Epstein, neonatal Epstein anomaly, especially the one that are very ill. And we are very happy to inform that lately we have been able to do the cone after start, because the start procedure gives a lot of hope. First of all, because you don't need to do a very complex operation, the tracheal valve, and in a newborn, very friable tissues. And also the patient can be in a place that the surgeon never had done a cone procedure. So starting a little baby like that would be difficult. So with the starting procedure, you stop compressing you occlude the tracheal valve with a fenestrated patch. So that caused the right ventricle to decrease inside, and the pressure inside also decreased, especially the diastolic pressure. And then you stop pushing the ventricular septum toward the left side. So that allows the left ventricle to fill up completely. So you get like the format changed completely. Instead of being a banana shape with septum compressing, shifted to the left, then it shifts to the right, so the ventricle and diastole get much bigger and can pump much more blood that can serve the pulmonary circulation and also the systemic circulation. And this is very important because many of those patients can survive. Luciano was telling about the details that you have to change when you do the cone, the STARN procedure, if you are thinking about doing the cone procedure. So nowadays we did, in the Children's Hospital of Pittsburgh, 4 cases of cone after STARN. In São Paulo, we did some more cases, and I know of colleagues that have done more cases. So I know about 10 cases of cone after STARN. They are very successful. It's interesting that those bad ventricles, they get smaller. At one time, they are in good shape to be rescued and to serve as a right ventricle, either as 1.5 repair or a 2 ventricle repair. It's interesting that those ventricles, they improve the function. It's different than the bad ventricle, some bad ventricle that you operate in more in older patients, and you do the cone directly, because when you do that, the ventricle not always improve. And if you do in a younger patient, there's more chance of improvement, but you do a little older patient, then the ventricles stay big, compressed in the left ventricle, and there's an unsolved problem. Interestingly, that to observe that when you do the cone after STARN, those ventricles work well, the function are very good afterward. In all patients we did at the Children's Hospital, and also the one we did in Brazil, actually 2 of them, they have excellent function of the right ventricle afterwards, which is very interesting. So I think it's very important to have those images and to evaluate the patient, how the one we can do, how we can do, and that is very important information. So, and I hope that things continues to improve, that at one time we can print the heart the same form you have the specimen, because then we can really demonstrate, especially for the young surgeon, how to do the operation. And then you can do it much faster. Nowadays, if you do a complex cone operation, it takes sometimes 2 hours just to work in the tracheal valve. And that's a lot of time. And I hope with the future, with more anatomical information, we can shorten that time. So I think that's about it. I'm very happy that those contributions are happening. And I also want to thank Dr. Gil Bernoffs for for his work, intensive care unit, and special attention to Epstein anomaly. And also to my group in Pittsburgh. They're doing a great job. And together, I think we can bring a lot of more information that can help in the treatment of Epstein anomaly.
Yeah.
Everybody.
Can I, it's very unusual for the presenter to ask a question. First of all, Dr. Jose, it was fabulous. Thank you for everything that you've done to help us understand Epstein's malformation. Mm-hmm. The first question I want to ask you are 2 parts. How young is the youngest patient you've done a cone procedure on? And how old is the oldest patient you've done a cone on? And how is the longest survivor of the cone procedure in years?
Mm-hmm. Well, I start for the last question. The first patient I did was 93. She was a 12 years old girl. And she had a big heart, but Dr. Macruz, her cardiologist, wanted me to do because she was a small family. She belonged to a small family and she wanted to have a baby. You have to try to do the repair. And then when I saw the valve, I was already thinking of that design technique. And then I said, and then I did the cone, but the cone didn't work so well because I didn't delaminate well the tissues in that first case. And then she came back 4 years later and I complete the cone. Now it has been 28 years since I did the first operation. She's doing well. She had her baby. And the colony still works. So that's the oldest operation. Now the youngest patient, in the past, I used to be referred with babies, to do babies. And I had the opportunity to do one 4 days old. She had a good function of the right ventricle, but she could not generate pressure because the regurgitation was so intense. Pressure in the right ventricle to open up the pulmonary valve. So we compensate her and then we decide to do the valve. But then later we realized that those patients are in small number, maybe 20% of the critical Ebstein anomaly, and they require a lot of experience to do. So now we are prone to do in younger in babies, we're prone to do like the Stern procedure, which is, or sometimes we can do also a stent of the PDA. But if we open the chest to do shunt, then we prefer to do the Stern, because then if we have arrhythmia, we can repair the arrhythmia too. We can do it easily, very quickly, and then this make more sense, especially now that we're planning to do in everybody the reconstruction of this time. Regarding the oldest patient was a 67 years old lady. And what I have to tell about that is normally those patients, they die with Epstein. They have a lot, like a type A, B, a type C or D Epstein anomaly in Carpentier classification, they die young. We see a specimen, many specimens of very young patients that die with that disease. The one who survive are the one who has a better structure of the right ventricle. They have more normal papillary muscles available, and the functional ventricle has a structure that resembles the normal ventricle in most of those cases. But then when they get older, the pulmonary vascular resistance seems to get worse, and also the ventricle can dilate more, and then they compensate when they're old, but they have a good structure. If we get those patients, then we can operate with very good results too. But in the past, some patients with bad anatomy and that were not treated surgically, then they have a huge right ventricle. If they're old, like 20 years and older, they have very poor prognosis, even with a good repair of the tracheal valve, because then they have in most cases a irreversible situation of the right ventricle. That's why I call attention to do them earlier, sooner than later, if they have important anatomical disease or malformation of the right ventricle in Ebstein anomaly. Did I answer well?
Norman, are you happy with the answer?
I'm always happy with the answers. Thank you very much. I want to ask you, have you ever crashed a patient onto ECMO, Gil? Have you had any experience of an Epstein's crashing onto ECMO? I mean, because I think that the reason I'm asking the question is crashing perhaps is not a good adjective. I think planning may be a better adjective, because, you know, when we look at these babies in utero, we give you a lot of information about them. And perhaps some of them are so bad, and of course with the high drops, etc., maybe a consideration of crashing them onto ECMO is the best idea. Have you anything to say about
I
that?
do. It's my certain. Well, there's. I'm going to say two things that are very related. First of all, at the beginning, watching this presentation, I had gotten pretty cynical about 10 years ago. 15 years ago, there was nothing new in cardiac surgery, and there was an operation we could do for everything. And it is so encouraging to see what's being done with Epstein's. The collaboration between the imaging, 3D printing for that specific valve, and combining a Starnes procedure with a secondary cone. I mean, this is, it's really nice to see new stuff. That then brings new management strategies to the ICU because we're dealing with all new physiologies, right? Norman, to answer your question, we have, and Ricardo Munoz, who came from Pittsburgh, has really advanced a lot of this, as to think of ECMO not just for ECPR, but as a therapy, as a resuscitative therapy. And we have not gone to the OR with obstructed pulmonary veins in 5 years. Instead of putting them on bypass and fixing their veins, we'll go on ECMO and get everything together. We've done the same thing for transposition with intact atrial septum, and we've done 2 babies with Epstein's for exactly the same reason. They come out, they're in high drops. One, we had to actually do a mini sternotomy in the unit and close off the ductus, because although you're providing cardiac output with ECMO, you can have exactly the same circular shunt that we were talking about before. So each case is individual. Epstein's is rare. The stuff, by concentrating this in centers like yours, like Joe Durani's doing up in Mayo, that's the way to do this. That's the way to learn about this. And I think the work that's being done in Pittsburgh now and Mayo and a few others is exactly the right way to do it. Congratulations to both of you. And I'm realizing you're in Taormina right now. I just realized the 3 of you are sitting in Sicily.
Yeah.
We are sitting at Sasha's chair, and Sasha is in the OR, starting the case for them.
So regarding the ECMO, that is just one situation that ECMO doesn't go well. It's the circular shunt in the newborn. So in that situation, I think we should plan they did in Brazil in that case, to plan the delivery of the baby in one room and transfer the baby to immediately another room if the patient is in a very sick situation, because you don't have enough time. And if you go on ECMO, the circular shunt with the PDA open will not support the kid very well. So
yeah, like you said, Norman, this is now not only new surgical technique, but such important indication for fetal echocardiography to determine immediate planning. It's such a collaborative effort that's going on across all the subspecialties. It's extremely exciting.
Yeah, and I was going to ask too about the possibility, the way the things are developed in the imaging, the possibility of printing the images in 3D. Do you, Dr. Norman Silverman, do you have experience with that? Have you seen good printing? Printed images?
The problem, though, 3D is printed off either CT or MRI. Okay. Mm-hmm. And the problem with those techniques, the unfortunate problem, is you can see the valve, but you often can't see the tendinous cords. And even looking at the valve, if you look at Si Jun Yoon from Toronto's printed experience, I have some of his pictures, the hearts are exquisite. The structure is exquisite, but the valves, because they move, because the magnet is taking a picture in the cardiac cycle at some period of time, they aren't that as good as you'd like them to be. Now, I have no doubt, open it up, look at the valves.
So
now,
this is from our colleagues from well. So it's
just
it's not
quite good enough. Yes.
The valves are not still,
Right.
I think we're going to evolve for that, but still is not that good definition. For all the rest, it's amazing.
It will get better, just like our
Yeah,
desk
that's what I
valves.
They
think.
will get better for sure. I mean, you know, this isn't the end of CT and MRI. It's just the beginning. and I mean, I think that CT is particularly because of its better spatial resolution. When you talk about a tendinous cord, you're talking about something that's under 0.5 millimeter of thickness. We're down at the resolution of the technique now, and that's what you need to do to see the tendinous cords. And I think, you know, certainly if you look at the stuff that they're doing in Toronto, where they print these and have surgeons come in and fix these, that's going to be fabulous. But I still think for fine valve anatomy, it's still a combination of ultrasound techniques that give you the best and instantaneous thing, because it's not the difference between the CT and MRI and the 3D echo and the 2D echo is the one is real-time live imaging and the other one is a synthesis. And that's still the problem with as far as I can see it now. I'm no expert on CT and MRI, but it's quite difficult to see the quality of those things. Yeah, I've got a heart with me now. This is a crisscross, Grace, as we all do that. This is somebody gave me this, a crisscross heart. And here is opened up a crisscross heart. I want to just get it in the right, so the focus is good. But you see, the valves are not really perfect. And this one is one that made out of silicone that the surgeons could operate on. It's not bad. It may still be subject. I don't know why my camera is not. I don't know. Can you see it?
Yeah, we can.
Yes.
But this is
Because of your back, it's because of the background, the blur effect, Norman.
no, it's me blurring.
That's the M mode. That's the M mode.
I blur myself as well.
That's the M mode of MRI. It's going to get pretty soon. It's going to get better.
Yeah. I believe on that as well. We'll
Yeah.
get there.
That would be very helpful. Yeah,
I think that's in the offering, and I think that you know, the technique that they're using in Toronto, the fact that you can teach a surgeon now to operate, not only a trainee, but even maybe somebody to look at all of the details, that when you get in the operating room, you know so much more about what's there. You don't have to do a lot of exploration to do it. I think it's wonderful. And I must say that since 1988, the big issue in my life was we started a regular transesophageal echo in the operating room for Frank Hanley. And the thing is that, as they say about the stethoscope, it brings you that close to your patients. So you've got to be, as an echocardiographer, in the operating room with the surgeon, seeing what the surgeon did, experiencing what the surgeon did, and responding to his needs. That became the opportunity to do transesophageal for this, which I think is certainly for AV valve surgery. This is the most important aspect of doing a transesophageal echo.
Norman, perhaps you could share with the audience the important P's. I think there's 5 P's for the transesophageal echocardiographer. Is that
I hope
correct?
I can remember them. First of all, when the surgeon calls you, you have to be prompt. That's the first P. Okay. Then you have to be precise. You want to tell him exactly what he needs to know. Then you want to be pithy. You don't want a long description. You want to stick to the facts. And then you need to be always polite to the surgeon, because the surgeon is usually polite to you. And if all of those 4 criteria are accepted, the last P is protomine.
I thought the P was also the operation is perfect.
I haven't added that. We can make it 6 Ps.
This is so wonderful.
Most important and rewarding position, Gil, is when the operation is not perfect. I mean, and that's the other issue about transesophageal, is that when you go into the operating room, you're not representing the surgeon, you're representing your patient. And so it's okay to argue with the surgeon and disagree with the surgeon, because you're not representing him. We're not part of a chairing
Or
team.
her, or her.
Or her. Exactly. Thank you very much for that, Gil.
And also the surgeons should accept the echocardiography suggestion as help, not as a critic.
Yes.
Do you know the difference between an argument and a discussion? A discussion is to decide what is right, and an argument is to decide who is right. There should always be a discussion.
So in the operating room, both has to be right at the end.
Well,
All right.
Oh, can I ask the surgeons? I have a question as well.
I've tried to answer a lot of comments on the questions over here. I think
Thank
that
you very much
they're
for
all
that,
pretty much answered.
Yeah, thank you. Because I don't think you're going to have time. We've been 2 hours already to answer live, unfortunately, all the questions. So if you can write on the chat would be great. And I think Gil has a question. I think he wants to show us something about the World Congress.
I do. I just want to ask the surgeons a quick question about their indications and how they determine whether a bidirectional Glenn should be added as part of a cone procedure, if at all.
Yeah, well, we consider that the Glenn procedure is not very natural procedure, because it results in the very elevated pressure in the upper body, and we don't know the consequence of that in the long term, especially when the right ventricle recover, start beating, and then generate a high, sometimes high systolic pressure. But we understand that many times it's very important to save the life of the patient, and but we do it very few cases. We prefer to leave like a pop-off type of atrial defect, where we establish the valve mechanism of the PFO, allow the blood to go from the right to the left, so the right ventricle recovers, and the patient then doesn't need that anymore. So start improving the O2 saturation, decrease the shunting, right to left shunting. So, but nowadays we think it will be important, even in case that the ventricle doesn't work well, and even after the cone procedure, that is also not, or any repair of the tracheal valve that is not function very well, then we can have a temporary relief of the hemodynamic situation. And sometimes I think we can even add like a Starn patch to those patients, and because then we stop compressing the left ventricle and the patient improves, and then in the future we might be able to remove that patch. So I think it's a temporary maneuver that should be used in a few cases.
So if I'm understanding, and I've spoken to Dr. Durrani about this a number of times, a simultaneous Glenn with a cone is not an approach that you have traditionally taken. Is that correct?
Right.
Did I understand that right?
That's right.
Okay.
It's always an option that after the operation, we can decide, but I have decided that in only 2 situations in my career. So
okay, thank you. That's very helpful. Do I have time to share this with the audience now, Grace? Is that okay?
Yes, let's try before we say goodbye.
All right. Do you see the presentation now?
No.
we size more.
We saw your screen, but just like a find file.
All right, let me try this.
We'll do this, guys. So we see your presentation now.
And now if I hit presentation mode, do you see it?
No, we have a speaker mode.
Okay, so I'm just going to show it from here, okay?
Okay.
So is it filling your screen at least?
Yeah, we can see it very well. Don't worry.
Okay. So Grace, this is even new to you, this presentation. I'm really happy to
I'm
share
so
this.
crazy to watch it.
Yeah, just some background. Jeff Jacobs and I are the two co-chairs, and we started planning for this in 2009. We won the bid in 2015. It was planned for 2021, but COVID came, and so we're now planned for August 27th through September 1st, 2023. This is our executive committee. I want to go through this pretty quickly. Here is our marketing and social media committee. Grace is on two committees, both the marketing committee and the educational committee with the Children's Heart, with the Congenital Heart Academy. This is Rob Pass from PD Heart over here. This is Justin Treader from Heart University. And this is our financial committee, Mike Fundora, Lindsay Justice from Cincinnati, and Sri Desmadi from here in Washington. Let me see if this runs. Tell me if you can hear the sound.
Yes.
This is 2 minutes of your time. Just a few other things that I'll say. It's a large program, as you can imagine. There's going to be about 1,000 to 1,200 invited speakers from all over the world, every continent except from Antarctica, and hopefully most of the countries in each continent. Here are the 22 tracks, and all of this will now exist on our YouTube channel, and the Congenital Heart Academy YouTube channel. And it will also be on our website, which is down here in the bottom right-hand corner, which will be live in about 1 week. To give you an idea of what the cores may look like, this is just as an example for rheumatic heart disease, with the featured plenary congress on what do we really know about rheumatic heart disease, case presentations, emerging science, reactions to white paper presentations. This is a global meeting, not to go into every single talk, but every single day, 4 to 5 collaborative sessions will take place, such as cath in low and middle income countries, sharing things through telemedicine, et cetera. We have an advocacy and collaboration track with parents and patients and parent support groups. We have an entirely new track on cardiovascular disease in the neonate, including a track combined with the Neonatal Heart Society, the Cardiac Neurodevelopmental Outcome Collaborative, and the Pediatric Cardiac Intensive Care Society on stabilization and management of the neonate with critical congenital heart disease as a plenary session. And a huge program in surgery, as you might, and I didn't put this on just because the Silvas are here, Luciana, but Jeff Jacobs has done a wonderful job of collaborating with multiple societies for the congenital cardiac surgery track, surgical videos, hands-on presentations, specimens where attendees can practice in a proctored environment. There will be abstracts in 15 of the sessions, so we'll have about 139 oral presentations. And then we're using an audience response system. So of the 15 tracks, we will have 15 best abstracts, one in best science, one in echo, one in ICU, et cetera, et cetera. And then on Thursday, those abstracts will be presented. So if you are not, for example, up to date in neurodevelopment, there will be the best abstract from that session, all shown in one time. And then we will vote on the best abstract. Norman, I had to put this picture up here because it's one of my favorite. We are working together with a number of physicians, and Norm will, you'll hear a lot more details as Justin Treader gets this together, but we're planning to have a space dedicated multi-dimensional anatomy lab going from the 1900 Maud Abbott type specimens through 2D and 3D and 4D analyses with world experts, as you can see here, Diane Spicer, Norm Silverman, Merrill Cohen, and hopefully Bob Anderson will be interested in traveling. I apologize again for the noise in the background. I'm right next to the helicopter pad. And as you saw before, I'm going to just skip through this. There are multiple societal partners that are helping us out. That we're expecting somewhere between, we don't know with COVID, but we're expecting somewhere between 4,500 people and 5,000 people. But of course, we'll never know that for sure. I'm going to unshare my screen if I can. And I can certainly answer any questions that may come up at this point. It's not giving, can you, oh, here we go. I found it now. Okay, hi.
Gil, beautiful video. I was crazy about to see it.
You are all the first people to see the video. I got it this morning from our graphic designer.
We've been waiting in the committee for a long time for this video, and it's just worth the wait. It was amazing.
I'm glad you liked
it. No, I really liked it. Passes the message that we've been talking all of this time. Perfect. And we're sure you guys are going to see this a lot during this next year, because we hope to share this video and the presentations and the meetings around the world. And so you guys cannot forget about the World Congress. And this is going to be amazing. We are so happy to have all of you there. This is really going to be.
We've learned that the attention span of the younger generation is probably 15 seconds. So I'm hoping that we can put together these 2-minute videos and hold people's attention. The entire program at a glance will be ready in about a week. There's a number of videos about Washington, D.C., and then the anatomy lab, which we're so excited about.
Okay, guys who are watching us now, could you just type on the chat if it's a good video or not? If it's conversation up, you got bored. So if you could just say nice or not nice, and would be very helpful, so we can have.
Well, what's missing? Yeah.
Yes, what's missing,
we want the stuff that we need to do better.
Yes, that's it. So please do it now. We are going to be very happy to see the feedback.
Obviously, really, we need more pictures of Norman Silverman. I know that already.
I want to get that picture that you have of Merrill and Bob.
I'll send you a copy, Norman. I owe you a phone call. Let's try to do it soon. I'm on service this week, but I'll not that everybody needs to hear.
I want the picture of you in your Indian outfit in Florida that you did one year together.
I am not sharing that one anymore. It's been such a pleasure I'm on service, so I'm gonna have to run.
And we have to go as well.
It was great.
Oh my God, guys, thank you very much for being with us today. If you like this presentation, please share with your team the link on YouTube. This is going to be there on the YouTube. So you can see this again. It's a very complex disease. It's worth watching and stopping the video. So please do that. Norman, beautiful presentation. Really, really beautiful.
Thank you.
I've learned a lot. Thank you very much. Thank you for joining. We always love when you're here with your input. And José Pedro and Luciana, you both live in my heart. And I'm very proud to be Brazilian and to just say that I work with you, that I'm friends of you, and you've done an amazing job on this disease and so many others. Thank you very much, guys.
Thanks very much.
Sorry, I couldn't be with you in person today. I really am.
Oh, no.
We all should be in Sicily. There's no question about that.
Yes,
My favorite place to visit.
Taormina's a better place, I can say that.
And I did want to say that Pittsburgh is my second favorite city in Pennsylvania, after Philadelphia, where I am from. But Pittsburgh is actually a beautiful city. I love it there.
Yeah,
I think it's.
I like that.
It's certainly
Wow.
improved a lot over the years too.
Yeah.
For
I
those
hope
of
I
us
get a
that
chance to
know
see one of
Pittsburgh
these.
from a long time ago.
Amazing. Guys, we are going to receive a link or by email for the survey for this talk. If you have comments about the video as well, you can write on the SurveyMonkey survey, okay? It will be very helpful for us. Thank you very much, guys. See you.
Goodbye. Have a wonderful day and good luck in the operating room, Dr. De Silva. I'm sorry I'm not with you.
So much.